lumps or bumps. And then you're gonna feel me kind of move to the right and the left side to see if I can feel those ovaries. Ovaries are about the size of a grape. They're really tough to feel. So as you go in, you're going to feel the cervix. And as you feel the cervix, you're going to kind of initially move it to see if there's any cervical motion tenderness. Okay. And then as you feel the cervix, you're going to push those fingers up and push down on the abdomen and see if you can kind of trap that uterus. The uterus is about the size of a fist. That's how I always classify it. And so I'm trying to see, is the contour, is it soft, as in like and smooth, okay? Or does one side feel bigger than the other? Then you're going to move into the right or left adnexal area, I don't care. But I'm just going to kind of move into the right area and go in right into the groin area and push. And you're going to have to kind of really trap and kind of sweep towards yourself. So you kind of sweep. And what you kind of feel is just a little kind of bump. Again, it's the size of a grape. Not kidding. Then you move to the left. You do the same thing. So that's your bimanual exam. Women who turn 40, they start to do what's called a bimanual exam with, it's called a rectovaginal. So what most examiners do is, they know they're going to do this, they put 2 pairs of gloves on, and then they take their top ones off. Okay? Or you can change gloves. So what you're going to do is you're going to insert your index finger into the vagina and your middle finger into the rectum. What this allows, it allows about 2 more centimeters into the pelvis to get a better feel for any masses. It's also, you can use it as a colon cancer screening test at that point because you guaiac it. But again, it's not the recommended thing for colon cancer screening, we know that. But it gets us further in and feels, you can feel the uterus, okay? But it's the same procedure and the same feel. Hand on top, over the uterus, and still kind of pushing because you can get to the back of the uterus better. Okay, so PMS, endometriosis is excessive endometrial tissue growth, okay? Outside the uterus, it can be actually anywhere in the pelvis and higher, even into the abdomen. It's very painful, worse during menstruation. These women have a lot of excessive bleeding. They usually come in because of pain. They have dyspareunia. You guys know what that word is? Pain with intercourse. So that's always a question you ask. Is intercourse painful? STD lesions, if you... Amy, how many questions do you think on the board are on STDs?
I just took it. I probably had at least 5 or 6.
5 or 6, yeah.
There's a high percentage of OB/GYN questions.
Yep. So know your STDs, know your STDs, know your STDs. Okay? So you have primary lesions, secondary lesions, secondary, so condyloma latum or LATA is your secondary lesion of syphilis. It's kind of a plaque. It looks like a wart initially. It looks wartish, but they have syphilis. So HIV patients, you want to be thinking this. You may not know they have syphilis. Okay? If you see a wart-like lesion of HIV, you better know their whole sexual history. Genital warts, herpes, painless lesion, painless lesion, painless lesion, painless lesion. One lesion is syphilis. Okay? Herpes, very common. Genital herpes, common. 1/3 of the population has herpes. And usually they come in saying, it burns when I pee. It burns when I urinate. It's not true dysuria. It burns on the outside when they urinate. Or they come in burning when it urinates. So when someone comes in with urinary symptoms, burning when it urinates, you need to ask about, do you have any lesions down there? Do you have any rash? Do you have anything going on? That should be part of your GU review systems or HPI. So that's the syphilis, primary ulcer, okay, genital warts, herpes. That's a classic picture of herpes. Okay, very classic, small ulcerative lesions. There can be in multiple stages of healing. So initially, you may see some even vesicular look, but hardly do I see it in the vesicular stage, because that's just the first day or two, but they're ulcers. That first picture obviously is herpes simplex 1, but genital herpes, herpes simplex 2 is genital herpes. Trichomonas, trick. Green frothy discharge. Know that, put that in your mind. Green frothy discharge. It truly is green frothy discharge that is frothy out. It's been on my pants before. It's that frothy discharge coming out. It doesn't, yes. Send myself for that. Yes. It's usually pretty copious. There's a lot of discharge. It doesn't have to be that way, but it's green. It's kind of gross myself. Strawberry cervix also goes with it. Frothy green discharge, strawberry cervix. Know those words, okay? They're descriptive in your note. It's what you're looking for on your physical exam, is a strawberry-looking cervix. So that's how you note it, it's what you're looking for, and that's how you diagnose it by your physical exam and history. What do you see on a slide? You see little flagellated protozoans, okay? Bacterial vaginosis, it's a fishy odor, okay? It's a thin gray discharge. Patients will actually even say it's kind of clear, but it's usually kind of more of a gray. You can get a little green to it, but it's usually this gray discharge, but it's an odor. I can pick anyone out in this room if they have it. My nose is that acute to the smell. Once you've seen a patient with bacterial vaginosis and you've experienced it, you will never forget it. I can walk into Walmart and pick it out. I think I'm joking, it's a true statement. I don't mean it bad, it's a very distinct smell. It's the first time you ever smelled C. diff. You'll never forget the smell of C. diff. What's another distinct smell? Pseudomonas. Once you smell Pseudomonas, you will never forget it. Once you smell strep throat, you can walk in and be like, you got strep. Done. It's just classic. So that fishy odor. And clue cells. Okay, clue cells. Candida. Any female who you see for repeat candidal vaginal infections, check them for diabetes. Okay? I've diagnosed more diabetes by vaginal candidal infections. Can't tell you how many. So, what question should I ask if someone has a candidal infection other than maybe some questions related to diabetes? But what do you think better answer this.
Antibiotics.
Antibiotics, absolutely. So, recent antibiotic, right, kills our normal flora, candidal infections will grow. Strawberry cervix, that's your clue cells. Dirty epithelial cells is what I call them, all spotty. Okay, candidal infections. This isn't a great, just Google trick. Just really, seriously, just do it, because you need to see them, and see if they have a video of them, because you'll just watch them with me. Tell you, it's, you think I'm wrong? I'm perfectly imitating those. I'm really joking. All right, gonorrhea, purulent discharge, okay, PID, chlamydia gonorrhea, think PID, it ascends up into the tubes and you can get PID, right? Chlamydia is a tougher one. They're a lot of times asymptomatic. They don't know, they don't have discharge, but they still can have discharge, yellow discharge. So that's why we always treat gonorrhea and chlamydia together. No matter what, if you have one, you treat the other. Always, always, always. Okay. This is my new part of my slides because Amy wanted me to teach this. This will be fun. Okay, so pelvic organ prolapse. It's called POP now. I didn't know it was called POP until I had to teach this. So I learned something. So, as I'm looking into the vagina, the anterior wall, we call it an anterior vaginal wall prolapse. It used to be called, or you'll probably see this, and people will say this, it's called a cystocele. So it drops down, okay? A posterior wall prolapse is called a rectocele. The middle, so it's, if you're looking in there, something's kind of coming towards you that you don't think should be coming towards you. It's usually a uterine prolapse. Okay. So the reason why they renamed it is because they don't really know what's causing. We really don't know that it's truly a bladder that's collapsing in anterior, or that it's just a rectocele or the rectum that's prolapsing it. But so that's why they got away from those terms. But cystocele, rectocele, you need to know that because you'll hear it. Okay. What do women come in complaining of? What's the signs and the symptoms? They feel like there's something falling out. They'll say that. I think there's something falling out. Okay. They feel like they're sitting on something, sitting on a ball. Urinary incontinence is a big one, especially stress incontinence. Cough, sneeze, jump on a trampoline, anything like that. I say that because I had my first experience with that. I know this is too much information, but it really is kind of funny. I was jumping on a trampoline and I was like, I really had to go to the restroom. And I'm like, jump, oh, I gotta go to the bathroom. I'm like, is that really what that is? I know, it's funny, but I got a trampoline and I'm kind of excited about it. It's fun. My daughter's all flipping around and doing all this kind of stuff, and I'm like, I can jump for about 3 minutes. I'm tired. But it is really common in women, but it's kind of going along with all the other symptoms. So they kind of have discomfort, pelvic discomfort. They actually may have to insert their fingers into the vagina to urinate or to defecate. And believe it or not, that is a true story. They actually have to put pressure on that bladder so they can urinate, because they kink off the ureter. It kinks off the ureter as that bladder falls down. They may be constipated, and there are significant uses of they use a lot of laxatives. So they're taking laxatives all the time to actually to use the restroom, to have a bowel movement. Okay? They don't have intercourse anymore. Okay? Or they have a sensation and truly the medical term is looseness during intercourse. Okay, so how do they grade this? This is just, there's lots of different grades. But think about, so grade 1 is just above the hymen. Okay, if you look at a female, the hymen area, it's just above that. Right to the hymen is grade 2. Beyond the hymen is grade 3. And actually, if the organ comes completely like a uterus, it's a complete, so grade 4. That would be kind of an example of the stages there. Just a picture of it. This is from Access Medicine. You can go read about it. It's a good book that I use that's on there. Is it on there? No. Is the book on there? Okay. So ask about these things that we just talked about, so you can make sure that you get the whole history from them. So you may have to, if they talk about urinary problems, ask them all the questions we just talked about. Can you empty completely? Do you have urgency? Do you have frequency? Do you have incontinence? Do you have to, if you can't urinate, if you have any problems urinating, if you kind of get some hesitation, do you have to do anything to help yourself urinate? Do you have to, do you have to put anything into the vagina to help you urinate? Ask those questions. Okay. So how do we examine this? Well, the first thing you do is actually do the bimanual exam. Okay. Because you can kind of feel for any type of deficit. And actually what you do is you do a bimanual exam and you actually have the Valsalva. Because increasing pressure will really accentuate any type of prolapse. Anterior, posterior, and right in the midline. You'll actually feel a uterine kind of come right down and hit the finger. The other thing you're looking for when you have them do that in Valsalva is loss of urine. So they will actually urinate when you're doing that, from the loss of urine. Because they can't control it. The next thing is to do a speculum exam and have them Valsalva, which is a little bit difficult, obviously, because I am blocking both the anterior and posterior walls with the speculum, right? But I'm not the midline, or the mid area, the middle part. So I can see a uterine, or I can see that cervix actually as they Valsalva come at me. So it'll really move as they Valsalva. As you remove that speculum, you can kind of actually see it. You may see that anterior wall drop down, so kind of really watch that as you're withdrawing that speculum. The other thing is these you can actually take off and use and place within and look. As I put that in, I can push down enough, okay, to look at the anterior wall. I can invert it, trying to not hit, make sure that anterior wall externally, that as I do this, I'm not putting pressure like this, right? If I do this, where am I hitting? Right, I'm hitting the pubescence with the clitoris and the urethra, right? So what you want to do is do this. So push up like that. So the pressure to open up that vagina is as I insert this, I pull this way. So the pressure is lifted inside, and I don't put the pressure here. Okay? So then I can look at that posterior wall. And again, both of those, as I put those in, I have them Valsalva once I've inserted that speculum. Okay? If I can't see any prolapse, you can actually have a patient stand up and perform like a bimanual exam. because gravity, and think about the way the uterus sits, will actually make the prolapse worse. And you could do like a bimanual and have Valsalva. So most uterine prolapses, partial prolapses, it occurs when a patient stands up and starts walking and doing a lot of things. And a lot of women will, some people have complete, it'll just kind of come all the way out, and they actually have to push their uterus back up in. So, okay? So, there's some treatment options. So you can do Kegels, especially with some real mild, like grade 1 and stuff. Especially, why are we doing this? Mainly it's because women are embarrassed because you're jumping on the trampoline and you pee a little bit, right? So you're embarrassed by it. So you do some lifestyle modifications. You lose weight. You empty your bladder. You do some Kegel exercises. Smoking's supposed to help. And obviously you're going to have to treat people who have constipation problems. So increase fiber and decrease foods that cause constipation. Kegel exercises are hard. You have to do about 100 a day to make a difference. And you have to be able to do them. So to sit here and go, am I contracting the right muscles, right? So most people don't know those muscles. They don't get it. They don't know how to do a Kegel exercise. So you can actually send, some physical therapists are trained in Kegel exercises. Not very many, but there are. It's biofeedback, okay? There's also the picture here. Can you see it on the bottom? I labeled it, I just can't see it here. What are you laughing? How do you think they do it? How they get biofeedback?
Yeah.
Is that what you're asking? It's electrical they use electrical stimulation to the muscles, the nerves that contract in that area. Okay. Oh, these are Kegel cones. So, if I insert those into the vagina, I have to contract the muscles. Keep those there. Right? So it makes you isolate. I'm really not doing it. I'm acting to increase the power of your education right now. See? Because you watch me and everyone laughs. You're going to remember these Kegel cones forever and ever. So anyways, if you place something in the vagina and they have to actually keep it there, you could actually put they can be different weights. So you train it, the muscles, and it's kind of like anything. You have to train muscles. Your brain to contract the muscles. Okay, pessary. So he said, make sure you teach them about pessary. And I said, I didn't even know about pessaries until I was practicing about 9 years. That's how ridiculous this is, because I was never taught about pessaries. And I don't think people talk about them much. But they're actually used more than you think they are. But a pessary is something that we insert into the vagina to keep things from prolapsing. And they're actually a really good thing. Okay? But the issue is, you want to use them short term, especially if patients are waiting for surgery. And you may use them long term for patients who don't qualify for surgery. Because ultimately, really bad, like grade 4 obviously need surgery, or failures in conservative treatment, or someone just doesn't want to do pessary. But they're really a great thing for these people. Problem is you have to get them in, and you have to keep them clean. So, it's recommended that they're cleaned about once a week, or at least come in to see a provider once a month to take them out and clean them. But they're very difficult. Because I'm telling you, the first time a patient came in to see me, she said, "I'm here to have my pessary cleaned," and I went, "Are you speaking my language?" Because I don't know what you were talking about. I'd heard the word, but I had no idea really. I didn't know what to do. So I went and talked to one of the geriatric guys, and he's like, "Man, you just go in, you pull it out, you clean it, you put soap and water, and you put it back in." And I'm like, "Are you still, I know language barrier here?" So I YouTubed it. So these are what pessaries are. It's a very stiff, hard rubber that goes up into the vagina and holds whatever problem is going on. If you have a cystocele or a uterine issue, it holds it. There's even some for rectoceles or a posterior wall prolapse. So they go up into that area. Okay. You need to know about this because you're going to see it, and I don't want you to be like me, who had no idea what they were. This is just something to read on pelvic organ prolapse. I thought it was really good. So you can read that. All right. This is a video you all can watch before. We're going to meet next Tuesday. Is it Tuesday, Amy?
Double check. I thought it was Wednesday, but I could be wrong.
Wednesday. I don't know, but next week we'll go through really short, but watch this video. I am gonna play this video because there's a couple things I'm gonna stop and show you not to do. But he does a really good job on this video on teaching the exam. Other than his external exam, he's a little rough. Okay.